Welcome to impactID Clinical Insights. This discussion is an HCV primer for primary care physicians and is moderated by Dr. Kenneth Sherman. Our panel discussants are Dr. Marion Peters, Dr. Mark Sulkowski, Dr. Arthur Kim, and Dr. Kristen Marks.
Hi, I'm Dr. Ken Sherman from the University of Cincinnati, and I'd like to welcome you to the HCV Primer for Primary Care Physicians. In this, we will discuss core aspects of HCV infection and treatment for the non-hepatologist. I'd like to thank the distinguished members of our panel who have joined us today. More and more people are learning that they are HCV positive and are seeking treatment. Primary care practitioners will need to screen and identify those patients with this infection and then recommend treatment approaches that are rational for their patients. We're going to delve more deeply into that topic now. First, Arthur, are you aware of any data that provides us with some basic knowledge about the level of training and understanding that most primary care physicians in this country have regarding Hep C?
That's a great question, Ken. I think that at the moment we sort of lack data in terms of truly understanding what provider knowledge and as well as provider attitudes are towards hepatitis C. We know that there's been a big push lately to do at least baby boomer screening of those born between 1945 and 1965. And at least anecdotally, I can say that this can happen for some time when you inspire a primary care to do it. But in the end, how is that sustainable, and how do PCPs really maintain that, since you have to screen up to 30 people to find one case, and you can really get fatigued doing that type of screening. So I would say this is a ripe time to understand what are the barriers towards that level of hepatitis C screening, how much knowledge a PCP has. I think this is a ripe topic, but I'm not aware of systematic studies, and that might differ a lot depending on the region in which you're practicing and the level of training of your specialty providers in your area.
Okay.
But also the primary care providers have so much they have to do on a visit with a patient: high blood pressure, diabetes, cholesterol. We had a presentation from the hepatitis group in Washington a couple of years ago, and one of the primary care group said, if we did everything you told us, a visit would be an hour and a half. So I think we have to think of creative ways to help them screen. One such way is doing a iPad-based questionnaire for the patient before they go in. So are you born between 45 and 65? Flag, do Hep C. Were you born in China? Flag, do Hep B. That sort of screening that becomes automatic.
I think it may go a bit beyond that, actually. Part of it is why screen? And for a lot of folks, for 15 years, we used interferon or ribavirin, and we essentially did not set a rationale for screening identification. Patients were hard to treat, they were not cured, patients weren't eligible. Very few fields change this quickly. And hepatitis C has gone from a challenging disease for which nobody wanted treatment to a disease where almost everyone can be treated if they're diagnosed. But have we, and we know this as hepatitis C clinicians, but have we done an effective job of sharing that with primary care doctors, the rationale for why you want to know and offer patients treatment? The other fact is that the deaths we're seeing for hepatitis C is not something that registers. So I think we've got to stage the rationale for the screening.
We've had good testing since 1992, and we've had guidelines for who should be evaluated at least. So where did those go wrong?
I think a lot of people aren't aware of how many people haven't been identified, who have hepatitis C, who haven't been identified yet. That maybe up to 3/4 of people who have hepatitis C don't know it yet. I think people, if someone has abnormal liver tests, I think it does cross providers' mind if they're markedly abnormal. But if they're just sort of abnormal, they may not be thinking about it, or if they fall in that normal range that, towards the higher end, that probably shouldn't be considered normal. So I think that people don't realize how many people just don't know their diagnosis yet and would probably underestimate the number of people who haven't been identified.
How much do you think the contribution to that is that many patients acquired this many years ago and they don't look like the typical high-risk patient, the one that you would be worried about that's actively using drugs or in a situation socioeconomically where you may not think that Hep C is a factor?
Yeah, that's a huge part of it. And I think, some of the reasons people got infected carry stigma with them, and so people don't openly share that unless really prodded, and even sometimes when asked would just deny it. So that's where the age-based screening is so helpful in identifying people who have higher rates of hepatitis C yet, they had their risk factor so long ago that they're not going to be talking about it now.
Marion, could you review the age-based screening and what those recommendations are?
So the recommendations are that anyone born in the baby boomer era from 1945 to 1965 should be screened. And the reason for that is the vast majority of people with Hep C fall into that group, and over half of them don't know they have Hep C. They've never been checked, and nearly a half of them say they don't have a risk factor. So it's the richness of success that this is where you're going to find the vast majority of people, and you can remove the stigma but just say this is the recommendation that everybody in the baby boomer era be tested. And you don't have to say you have a risk factor, you don't have to say anything, that's your age, get tested.
Well, the other misconception that both patients, I think sometimes clinicians have, is that, well, if I was infected for 30 years, I would know it or someone would have found it. How bad could it be? My doctor would have found it. Well, a lot of times when you go back through the chart, you'll see an ALT level that was maybe 48 or 53. And it wasn't really high enough to get your attention. No one's complaining of symptoms. They're not saying, I want to be tested. So I think, in a sense, the silent asymptomatic nature of chronic infection kind of leads people, both clinicians and patients, to think that they're okay. But this is one of those things where you really have to pick up the rock and look underneath it and see if there's Hep C there by ordering a simple antibody test.
Anecdotally, I know that patients will ask for a test and sometimes be told, oh, I don't think you could have that. So these are barriers on both the patient level that Mark just described, the provider level that Marion described. Many providers trained when it was called non-A, non-B, and haven't followed this era into the 90s and 2000s and now into this incredible change in therapeutics. It's so dizzying that it's hard almost for us to follow, let alone a busy primary care physician. And so that's yet another barrier, is just trying to have providers fully understand what they're doing. It's as cost effective as many other interventions in primary care, if you think about it. You do it one time in the baby boom, you don't have to do it again, and then you can link people to treatment if they're viremic.
Will insurers pay for this, or is the patient going to be stuck with that bill?
Insurers will pay. Certainly Medicare, Medi-Cal will pay. I don't know about Medicaid.
Screening tests are covered by Medicare and other payers typically.
I think that there is probably coverage now because of endorsement by the U.S. Prevention Task Force. So I believe that shouldn't be a barrier. So let's suppose that a baby boomer is screened in a physician's office and it comes back positive. Are they done? Do they do additional testing? Where do they go with that next? And let's sort of we're going to branch into both sides. If someone wanted to do as much as they could possibly do themselves versus referring, and if you refer, then where does that referral go, and what are the responses that a primary care doc is likely to hear about regarding that referral? So let's start with what should they do next? Do they call the patient? They tell them, I found your Hep C antibody is positive. And the patient says, oh my God, what does that mean? What next?
Well, I think after setting the test, you have to be prepared to have that conversation. What am I going to say? So part of that is understanding what the next steps will be. So the recommendations for screening do have a couple of steps. One is to confirm chronic infection with an RNA test. I think that's something that could easily be done at a primary care level. They also recommend a screening for alcohol use and what's called a brief intervention. So even without getting into treatment and things like that, really talking to the patient about alcohol is important. But then the other steps are what next? Well, certainly I'd want that patient to know that there is treatment available. I wouldn't expect the details to be discussed, but they should know it's treatable. And I think they should use the word it's curable. And that's a word we need to get more comfortable with because it's a scary time to be diagnosed. I think what we're doing is curing patients. A lot of my colleagues do as well. That should be shared.
All of the papers you read about this still talk about SVR. What is that?
That's a cure.
A cure.
That means you
then
don't
why don't
have...
you use that word, Marion?
Because in the old days, when we only had interferon, sometimes the SVRs weren't permanent because the level of the sensitivity of the test was such that it may have dropped but then came back when you stopped therapy some months later. Whereas now it's very clear a sustained virologic response is a cure. It doesn't mean you can't be reinfected, but you're cured of this infection.
Okay.
I also think the provider should be ready for the patient to be quite alarmed, and especially with the baby boomer screening, many people really may not remember their risk factor, or it's not something that they are talking about or have thought about lately. And many patients who come that I see for the first time in consultation that have been picked up by this type of testing, just burst down in tears in my office. And I may be the first person they've talked to about it since the diagnosis, and they're extremely disturbed by it. They don't really understand, the risk factors for getting it, So I think explaining some education about, the ways it may have been contracted, and as well as, do they need to worry about their immediate family members? I think those are things a primary care doctor also can really, in that interim while they're waiting for their referral, take a lot of stress and anxiety off of the patients.
In some ways, it's actually a good thing they were diagnosed, because the worst scenario is that you live with chronic hepatitis C and progress to cirrhosis and your liver begins to fail, and then someone finds you because you develop ascites. So in a way, this is actually a good thing to identify the infection. But I agree, this education part does need to start with that first call or first office visit.
I think framing it like that's perfect. We're so lucky we caught this. This is, treatable, and we're going to get you into some good hands who can treat it.
And also the idea that curing hepatitis C will also benefit diabetic patients, will benefit kidney disease, will decrease the risk of inflammation, so it's been shown to decrease acute coronary syndrome, stroke risk. So there are lots of outside the liver benefits for curing hepatitis C, and the primary care physician is the perfect person who's looking after the whole patient to discuss that with them.
So let's suppose that they do have to make a referral. How are they going to decide where to refer to? Who does that patient actually go to, or does it vary dramatically around the country?
I think it can vary quite a bit who can provide the comprehensive evaluation and the potential treatments. It can be anyone from specialists here who have been treating this for 2 decades to people who are just getting into the business because the newer treatments are so well tolerated and so easy to manage that it is possible to establish more and more providers and provider networks in a region. So where there are providers easily available, perhaps that's the easiest thing to do. You just send them to somebody who knows. But if there is no one in your area, I do believe that there are ways to set up programs to gain the education necessary to establish programs even at the point of care within primary care clinics. There are many models of this, both here in New York City where we're filming, as well as in other parts of the country where treatment has been brought to primary care, often with specialist backup. through the use of telemedicine or through the use of these knowledge networks that provide the knowledge to the person at hand. I mean, remember the old days where they'd have to come in 12, 18 times for an evaluation. If they have to drive 50 miles, that's a big burden. Now we can bring treatment to patients. If you don't have that, though, hopefully there's someone in your area who can provide that level of expertise both for the patient as well as the provider, the PCP's education.
I hear occasionally that referrals are made and then the physician who does the consultation tells the patient there's nothing to worry about, or you don't need to be treated now, and that the patient brings that back to their primary care physician and is very frustrated and unhappy at that point. They said, I didn't need to do anything, and you seem concerned about it. How should the primary care physician deal with that situation?
I think that's actually the message that's been delivered over the last decade with interferon-based therapies. So when a patient would show up at a specialist office, they would be told a couple things. One, we need to do a liver biopsy. Don't worry, it's just a procedure. We'll take a piece of your liver with a needle, but you'll be fine. That's a little disturbing. And then the second thing was, we're going to, if you need treatment, we're going to give you shots of interferon once a week for 48 weeks. It'll make you depressed and tired. Your hair might come out, but people can get through it. So a lot of people went back with the idea, I don't want treatment. Or if it was a practice where they weren't invested in that difficult treatment, they'd go back and say, well, you know what, you're fine. Go back to your doctor. So, I think patients aren't going to have that experience now. I think that's an experience of yesteryear. Now it's going to be, we can stage your liver disease using non-invasive technologies or blood tests, and I'm not going to give you interferon, and the treatment's going to be brief. I think it's a re-education process.
But it's also a re-education because 20 years ago we weren't treating people who had no liver damage as best we could assess, because we thought those people may not progress. And it's true, many of them may not. But now we're aware of all the extra benefits to treatment, not just to the liver. And it's true, some patients may not progress to cirrhosis over 30 years. It's not an all or nothing. But also the multiple other benefits I was talking about before, that it's becoming clearer and clearer that curing this inflammatory disease improves quality of life, improves comorbidities. And I think education of the primary care is really our job to do that, because we've spent 20 years saying if you didn't have fibrosis, you didn't need treatment. Yep. Well, we were wrong.
It's changed.
Yeah.
It's changed.
Well, I don't know that we were wrong. With the tools we had, interferon, that was like a sledgehammer. I think now we've got more of a surgical knife to eradicate hep C. So I think in the era of interferon, that was okay to defer, but I think there'll be a different experience now when patients, at least when they show up in my office. Ken may recommend a biopsy, but we're no longer recommending biopsies for most of our patients with routine kind of no concerns about their hepatitis.
So what cure rates should be expected by these primary care physicians? What do you think we should have as an expectation for cure today?
Well, all the studies say cure rates over 90%. If you look in real world, it's probably 80%. But that's extraordinary cure rates if you think of all the other diseases that we deal with. So I would say cure rates are very high. And the worse your liver disease is, the more severe your liver disease is, the lower the cure rate. We know that. So treating early is that benefit also.
Christy, what about side effects of these treatments?
So they're remarkably rare now. It depends on some factors about the type of hepatitis C the person has, what treatment they'll get, and what the different regimens are. But for the regimen I'm using most commonly right now, for the genotype that's most common, which is genotype 1, I'm using a combination of sofosbuvir or ladipasvir, which is a 1 pill once a day. We haven't really talked about the regimens yet, but using that regimen, most people have no side effects. Most people go through the treatment and come back and say they can't believe it was so easy, particularly if they've done interferon before. And they're just, in complete awe of how sometimes they feel better, sometimes they feel nothing. Sometimes, if they do have side effects, it's typically, I say 3 things: fatigue, headache, or insomnia. And those are the 3 I see most commonly, and whether I planted it in their head and that's why they're having, but even in placebo-controlled trials, there were some of those side effects were more common, but still not common, but more common than in the placebo group. So I tell people to expect no side effects. If we have to use ribavirin in a regimen, and the other regimen that's most commonly used for genotype 1A, which is again the most common genotype I see, does have ribavirin in it, as well as 3 direct-acting antivirals and ritonavir. That ribavirin can cause some anemia, and it is also a teratogen, so you have to be careful about for people who are of childbearing potential and their partners in terms of using that. But also very well tolerated. Ribavirin, if it causes anemia, can cause fatigue, but it's very manageable. I have not had one person have to stop these treatments since I've started using them, and I've treated a lot of people.
That's very different than
very different than interferon.
Well, and people can continue to work as well. With interferon, there'd be the concern, can I work? Or, doc, I'm getting married next month. I really don't want to be on interferon, or that type of thing. And here you say,
travel,
you know what? Travel. Just take your pills with you.
Yeah.
Don't forget to take your pills. I really tell patients, look, live your life on this medicine. It's not, you just have to remember to take it. That's all I ask. 84 consecutive days of dosing, but this is not going to hold you back. And I haven't seen a patient yet where that really affected them, where they couldn't work or function.
So I've heard that some people can't get these drugs because their liver disease isn't bad enough. And that seems to be in conflict with what Marion said, that there's all these great benefits. So what's that about?
I think it's mostly about a cost-saving measure. I think people are worried that if we treated the millions of people with hepatitis C in this country all at once, that it would potentially bankrupt the system. So being a little sensitive to that, people have instituted restrictions on treatment. That being said, when you're the physician with a patient and describing all the benefits that Marion just described, it's very hard to withhold a 90% cure rate from anyone. And so for the patient in front of you, it's an extremely frustrating experience. And I try to side with the patient, saying we're trying to get through this and trying to access treatment. And sometimes with persistence, you can achieve that. I say you have to be as persistent as the virus is persistent, that we have to be as persistent to get those meds. And we've been very creative. We've had people change insurers. We've had all sorts of solutions to try to get around some of the restrictions.
And we tell the patient at their first visit, this may take 6, 8, 12 weeks to get you the medication. There may be 1, 2, or 3 denials before you can get medication. This is not something you take to the pharmacy and start next week, even once we're ready to treat you. So patients have to understand that getting approval through insurers will take time.
And hopefully this will continue to evolve over time. The first of these highly effective, well-tolerated therapies really came available to us in January of 2014. And we've gotten more by the end of 2014, and now we've got at least a couple of regimens that can be used. And with that, there's the ability to plan and to budget. I think in many ways, the demand for these treatments was a bit unexpected. I don't know why, but anyone wasn't expecting it. But with interferon, it was a natural barrier. Many doctors didn't want to use it, many patients didn't want to take it, and many human beings were ineligible because of contraindications. Those all went away at the end of 2014. And that has led to an increased uptake. And to Arthur's point, I think some of it is trying to spread the demand out over time, not all concentrated at once.
So how expensive are these treatments?
Well, on the books, they're around $80,000, but in reality, all the insurance companies have made deals with one company or the other, undisclosed costs, but thought to be around the world about 40 to 50% of the list price. And some countries have even been more creative, like Scotland made a deal that if you didn't cure the patient, the drug company would give them the money back. So there are many different ways of of creating a benefit to the patient and a cost savings.
And is that considered cost effective? Are there studies looking at that?
Yes, there are cost-effectiveness studies that would suggest for any individual patient, you've just averted a lot of downstream effects. On average, people with hepatitis C seem to live 20 years less than if you're not hepatitis C infected, and we know that cure tends to restore much of that difference. Of course, you don't want to wait too long. If once one has cirrhosis and the risks of liver disease, you clearly remain at that risk to a certain degree after viral cure. But nonetheless, the survival curves then tend to converge and you restore a lot of that potential lost life. And so for any individual, that cost that we just talked about is clearly worth it. I think the major issue is largely the volume of people that need to be treated.
And are ready to be treated now.
Right, and in fact, in our state, in Massachusetts, our Medicaid or Mass Health program, there's one arm of it that is not restricting really whatsoever as long as you can show that I will follow this patient and guide them through treatment regardless of liver stage. And their data do not indicate that they've become bankrupt over this past year, that there still are natural barriers of getting patients to that point where they're getting treated. Despite the availability of these great treatments, of these well-tolerated treatments, they did not go bankrupt this year. They were able to finance the number of treatments that were accomplished through their program.
And I think as it's continuing to evolve, even if the patient you screen and identify can't be treated right at this moment because of some of these barriers, they can institute other changes that'll benefit their health in terms of, if they're now aware of the diagnosis, they may want to stop drinking. They can be educated on the risks of that. They can be other medications that they take that could potentially be harmful to the liver. There's benefits to them in terms of preventing transmission to other people. So, and then they can be followed to the point where hopefully very soon they can get the treatment that we all believe is necessary.
So is the limitation of the physicians to refer to a new barrier? Which is going to circle back to when are we at the place where primary care physicians should assume a bulk of the responsibility for these patients? Are there new drugs coming that are going to lead us to that place in upcoming years?
I think at the moment you need to, once you have a positive antibody, you need to know there's virus, as Mark said, because only 70 to 85% of people will have virus. So 15 to 30% will have been cured in the past spontaneously. So there are many patients who are referred to us who actually don't have chronic hepatitis C. They have the antibody, which they will keep for life. And secondly, you need to know what type of virus they have, the genotype, because the treatment at the moment is different depending on your genotype. And thirdly, you need to know how much liver damage there is, because the treatment length differs and the type of treatment differs depending on how much fibrosis you have in the liver. But these things can be done by the primary care physician if you don't use a liver biopsy, and then they could select who they wanted to treat. If patients had more severe liver disease or comorbidities or were co-infected, they need to see a specialist to get them through treatment because of drug-drug interactions.
So I think at this stage, kind of early, we're less than 6 months into this kind of new era of great treatments. I think most patients are still being treated by specialists, hepatology, gastroenterology, or infectious diseases. I think we're going to get to that point.
But I think we're going to get there in the future.
And what's going to really help is the strategy to have once daily regimens that combine several different medicines that are active against all genotypes. You can skip that genotype test, and one duration for all liver disease stages, perhaps 8 or 12 weeks. And that is the goal of the next generation of treatment. So when we get to that point, where if we get there, we won't have to worry about genotypes, or we'll still have to stage disease. I think that's going to be important, but the treatment itself will be relatively simple.
So that's been called Perfectivir, the perfect drug. Are we 5 years away from that, you think? 10 years? If each of you looks in the crystal ball, is there an answer at this point?
I'm guessing 5.
5.
I don't know.
Arthur, you have a guess?
Well, if you're talking about Perfectavir, where you could give a single injection of a long-acting and then not even have to worry about the adherence later, and that's safe, then it's probably 5 to 10. But I think the drug development has been so rapid that we're already seeing the inklings of this one-size-fit-all in development. So it's not far off. Mark?
I was going to say, the trials, these studies can be done relatively quickly because, well, first of all, there's a lot of demand for treatment in the trials, so they enroll quickly. Then the treatment course is as short as 12 weeks or less. So you've got about a month to enroll, 3 months to treat, that's 4 months. Then the outcome is no virus 3 months after stopping. So essentially, the studies can be done in less than a year, and the results come really fast. So the drug development for hepatitis C is moving quickly, and some of these one-size-fits-all strategies are already in what's known as phase 2 clinical trials that, if they succeed, will launch phase 3. So I think a 3-year window 3 to 5 years is reasonable. There's no reason to wait for those, and I think, to Marion's point, these therapies are definitely something that could be done in the primary care setting. It would, in the proper region where you have a high prevalence and motivation to treat. It's a lot of fun curing people. A
lot of HIV providers who weren't previously treating hepatitis C have started to uptake it, and I think that's sort of a sign. The first step. Someone who's experienced treating viral infections but has sort of stayed out of the Hep C business they now are feeling comfortable, and I think, like you said, it's only going to get easier. The other thing is there's a lot of, I think, reaching out if you aren't sure where to get help from. Many Department of Health have links to, have programs or can refer you to places to get help. For instance, the New York City Department of Health has a linkage to care program where they help providers find someone for their patient to see if they're having trouble. They also have a helpline where you can actually get mentorship in sort of how to treat patients. So I think when you're if you are motivated to treat people, I think it's great. I think it helps to have sort of a mentor or buddy who can help you with the first few to try to, and particularly, obviously, the complicated cases, having access to someone who's been treating people for a while or really has a good handle on these new drugs. But they're easy to treat with, so I think people could do it if they're motivated.
At our hospital, we are mentoring some residents who are interested in this and wanting to treat their few hepatitis C patients sort of on their own and accomplish all these steps from viremia to staging to treatment with backup. I think they're inspired because they've worked in the ICUs recently and have seen all the liver disease patients, the cirrhotic patients coming and suffering from this infection. And so they have that perspective because they've just recently trained. And so this type of model can happen. I mean, there's.
But in our clinics, we have a pharmacist who helps us with drug-drug interactions, and almost every big program, we can go to the pharmacists and they'll say, you can't use this drug, you can't use that drug. Now, the HIV providers have done this for years. The primary care providers have not. So this would be learning a new language, and I have to say I'm a neophyte in that too. So I go to my pharmacists and say, what should I change? What can't the patient take? Things like hormonal therapy have drug interactions, things that you may not necessarily think about, herbs and spices. So one thing is that if the primary care was going to treat, the primary care provider would have to learn how to interact on drug-drug interactions.
And there are a number of programs rolling out across the United States to engage and train anyone who's interested in learning to treat. There's the ECHO project that has been done in New Mexico, and that was done because of the large geographic distances between the university center and where the patients are. They're too far to drive. But what we've also learned in the urban setting, although the federally qualified health center might just be 2 blocks away, that could be a barrier to come into the academic medical center. So I think there are programs in place where we're actually training clinicians at those sites to deliver the care with backup, either by a video conference, teleconference, or just a couple blocks away for referral.
So, Marion, you're a hepatologist in a transplant center. Some patients are going to have to come to people like you. Who are those patients?
So the patients the hepatitis C patients that should be seen by a hepatologist are the patients who are in need of a transplant or have cirrhosis. I think cirrhosis in itself requires specialty care. Requires an endoscopy to look for varices. It requires 6-monthly imaging to look for cancer. And hepatologists have those programs, not to say others can't do it either, but if they're decompensated and not just ascites or encephalopathy, but an abnormal bilirubin, a low platelet count, a mildly abnormal INR, many physicians in the community don't recognize slight decompensation, and treatment for hepatitis C can make the decompensation appear to be worse, or it may be just the natural history of decompensation, which occurs about 5 to 7% per year. So they're the sort of patients we should see. We should see patients with end-stage renal disease because they're particularly difficult to treat. Patients with porphyria cutanea tarda may be more difficult to treat. But I think many of the common or garden hepatitis C patients don't need to see a hepatologist.
So in many ways, it's not difficult. You mentioned sort of a couple of routine tests. It's the platelet count, the albumin, perhaps an INR, and the bilirubin. So if the platelet count's low, the albumin's low, the bili is high, that may be someone.
Warning bells.
In fact, I like when you look at the CBC and the comprehensive metabolic panel, you can tell just by those kind of quick snapshots someone is in trouble.
Right.
So it doesn't have to be difficult to identify someone for whom that expert hepatology care is indicating.
Yeah, I think a lot of people, when they think of hepatitis C, they first look at the liver enzymes, and that's sort of their gauge, and it's remembering the platelets, the albumin, maybe an AST to ALT ratio, things like that.
What other resources could primary care physicians go to? Where can they learn more about managing Hep C?
I think all the large societies have training programs, ASLD, IDSA. There are some not-for-profits who give courses. There are courses in major cities 2 or 3 times a year where you can go and do a workshop to learn about hepatitis C. There are online courses. There are programs where you can learn about drug-drug interactions, like the University of Liverpool. You can go to their website and plug in the drugs, and it'll tell you green, okay, red, don't go near it, and orange, be careful. So there are a lot of resources.
University of Washington has a really beautiful kind of step-by-step training for hepatitis C, from screening to the drugs, that I think is a really good place for someone kind of just getting started.
And are there guidelines that people can refer to?
So I think that's, I'll start by echoing the University of Washington for educational. So Dr. Google can help you find it. Just Google University of Washington Hep C and it'll pop up. But the other resource that I hope is written in a way that's translatable to any clinician is HCV-guidelines.org. And this is a collaboration between the ID Society, the Liver Society, and the ISUSA, the Antiviral Society, to really come together and try to address everything from screening and diagnosis, the management of the really serious patients Marion was talking about, liver disease and renal disease. So it's a nice, readable source, and more importantly, it's up to date. It's updated after all the major conferences and publications.
Excellent.
Sort of a living document online that as new drugs are approved or new information is released, it's updated in real time.
Well, I'd like to thank the members of the panel, I think today we've heard about Hep C, that it's a common disease, that the population of baby boomers are enriched, and we can test for that by doing hepatitis C antibody testing, that identification of patients requires that you provide information to the patient, and that information includes the knowledge that this is a curable disease and that curing it will not only help the liver but may help a variety of other systems. The treatments are relatively short term, they're easy to tolerate, and they're getting better and better. As good as they are now will be even better in a 3 to 5 year time period. So there is a lot of hope for these patients. There's a lot of patients out there, probably several million, that remain to be identified and treated. And the starting place for that is with the primary care community. Thank you.